I limit my talk to the lung isolation techniques practiced worldwide by the expert, along with some tips and tricks I learned from the experts with whom I work. Quickly revising the anatomy and physiology of the respiratory system, especially the lower respiratory system. Trachea, the windpipe, extends from the C6 cricoid cartilage to the T4 to T5 carina. The distance from the incisors to the vocal cords is 15 centimeter, while that from the vocal cords to the carina is 12 centimeter. The offshoot of the right mainstem bronchus is about 1.5 to 2 centimeter from the carina, which is less as compared to the offshoot of the left mainstem bronchus, which is 4.5 to 5 centimeter from the carina. The right bronchus is shorter, wider. It's having a downward course and early ramification. This is the tracheobronchial tree showing 23 generation up to the 16 generations. It is a conducting zone, and from 17 to 23rd, it is the respiratory zone. This is a classic diagram from Miller's depicting the average diameters and the distances of the trachea and the bronchial bifurcations. There are 10 bronchopulmonary segments on the right side, and the famous mnemonic that is a palm tree from the apical, posterior, anterior, lateral, and medial on the right side, upper and middle lobe, and a maple tree that is the superior, that is apical, AM, medial, anterior basal, posterior basal, and lateral basal. And you get the 8 bronchopulmonary segments on the left-hand side due to fusion of the segments. In the physiology, the prime importance to us as anesthesiologists is the FRC, functional residual capacity. It is the amount of air remaining in the lung at the end of the normal tidal expiration. It prevents the alveolar collapse and it continues oxygenation at the end expiration. It changes with the change in position with the anesthesia and as per the body weight. Now, understanding the pressure volume curve, the transpulmonary pressure, it is the distending pressure, which is the positive alveolar pressure minus the negative pleural pressure. As we go down the lung from the apex to base, there is rise in pleural pressure by 0.2 centimeter of water per centimeter of the lung. So it is similar to an inflation of a balloon. We can see initially you need higher pressure to inflate the balloon, that is to open up the atelectatic lung parts. And after that, once some volume is achieved, even the smaller pressure changes cause a big change in volume. That is the steep curve of the pressure volume of the compliance curve, where the base of the lung can be correlated. And again, after the lung is almost fully inflated, to open up the residual apical area, you need some higher pressure. So that apical area is on the flatter portion of the compliance curve. As we know, depending upon the perfusion of the lung, under the influence of the gravity, there are physiological zones of lung, zone 1, 2, and 3. At zone 1, alveolar pressure is the highest as compared to P small a, pulmonary arterial pressure, and pulmonary venous pressure. This is a physiological dead space zone. In zone 2, that is the middle segment, you get an optimal gas exchange where ventilation perfusion ratio is 1, while at the base is zone 3, the VQ ratio is the lowest. Ventilation and perfusion both increase as we go from top to bottom of the lungs, but perfusion increases more as compared to the ventilation. In case of, while considering the physiology of one lung ventilation, a normal upright individual, the apical portion of the lung is on the flatter part of the compliance curve, while the basal basis of the lung is on the steep part of the compliance curve, showing it is more compliant. In lateral awake patient, in lateral position, you get similarly the dependent lung on a better compliance curve, that is on the steep curve, while the non-dependent lung on a flatter portion of the compliance curve, which is showing it is less compliant. As we anesthetize the patient, due to the supine position, due to the pressure from the diaphragm and the abdominal contents, along with the anesthesia drug effects, paralyzing agents effect, there is a change in the compliance of the lung. And when you paralyze the patient, you see this change in a shift of lung from on the compliance curve. Now the non-dependent lung, which was previously on the flatter portion of the curve, now moves to the steeper portion, so it becomes more compliant. And the dependent lung, which was more compliant in under anesthesia in paralyzed patient, moves to the flatter portion of the compliance curve. Now, when you open chest for surgical purposes, it becomes easier to ventilate the non-dependent lung because there is no resistance from the chest wall as the chest is open. Again, the surgical interferences, gravity effect, effects of hypoxic pulmonary vasoconstriction, they all cause the perfusion to increase in the dependent lung, but the non-dependent lung is easier to ventilate. So this causes a big ventilation perfusion mismatch. So application of one lung ventilation, that is the lung isolation, this forces the ventilation back into the dependent lung, re-establishing the ventilation perfusion matching in the dependent lung. And last but not the least is the hypoxic pulmonary vasoconstriction. It is an autoregulatory oxygen sensing mechanism which allows VQ matching by reducing the perfusion of the poorly oxygenated lung, as in the non-dependent lung. It reduces the shunt flow through the operative lung by 40%, facilitating safe conduct of one lung ventilation. It is HPV response is maximal when the 30 to 70% of the lung is hypoxic. It is a biphasic temporal response. It starts early within seconds. It reaches plateau at 15 minutes. And again, it is followed by late response with a peak at the 4 hours. What are the indications of one lung ventilation? Protection of the healthy lung, diversion of the ventilation from damaged airway or damaged lung, improved surgical field exposure. The indications for lung isolation where the use of double lumen tube is mandatory. These are protection of the lung from the contralateral lung contamination in case of lung abscess, lung cyst, pulmonary hemorrhages, and control and continuity of the airway or gas exchange in case of bronchial disruption, pneumonectomy, and bronchopleural fistula. The lung isolation can be achieved with the use of DLT or bronchial blocker in the relatively indicated cases. Those are the surgeries that require the surgical exposure through the chest cavity with a lung collapse like VATS, lobectomy, mediastinal mass resection, esophageal surgery, spine surgeries, and minimally invasive cardiac surgeries. We do it with the use of double lumen tubes, endobronchial blockers, and univent tubes. In case of emergency like chest trauma, you can also insert the single lumen tube far deep inside to achieve single lung ventilation. This is a diagram showing double lumen tube, the left-sided and the right-sided tube due to the inherent differences between the right and left mainstem bronchus. It is that longitudinally two semicircular tubes are molded and distally they are curved so as to facilitate the insertion inside the bronchus. There is a color-coded bronchial curve at the distal end in case of left-sided DLT with a similar blue-colored pilot balloon, and the tracheal cuff ends just above the distal tracheal lumen, which is white color-coded along with the same pilot balloon. A ventilator connector is also important. It is a Y connector which allows the ventilating both the lungs using the single ventilatory circuit. There is a soft tube segment as it is used for clamping and isolating the lungs, and the bronchoscopy port with a fish mouth valve to allow passage of bronchoscope. There is a difference between the right and left DLT due to basic differences. It is having a different shape, size, and design of the bronchial cuff. As shown in the middle image, there is a ventilatory slot for the ventilation of the right upper lobe. The figure on the left-hand side shows the different manufacturers have different types of right DLT. The Sheridan is also having two bronchial cuffs, and between them an elongated ventilatory slot to ventilate the right upper lobe bronchus. Now, which DLT to choose? Rubber DLTs are out of market. They're having high pressure and low volume cuffs. We use disposable single-use plastic DLTs. Most elective thoracic surgeries are successfully managed with left-sided DLT because it is having a greater margin of safety. The absolute indications for right-sided DLT is the left lung transplantation, left-sided sleeve resection, left pneumonectomy, compression of the left mainstem bronchus due to the descending thoracic aortic aneurysm, or the distorted anatomy of the left mainstem bronchus due to the compression by tumor. Or now the margin of safety is defined as the length of the tracheobronchial tree over which the DLT may be moved or positioned without obstructing the conducting airway. In the left-sided tubes, the margin of safety is the difference between the length of the left mainstem bronchus minus the proximal cuff to tip distance. So it is more as compared to the right-sided tube, which is shown in the below figure. This margin of safety is the difference between the length of the right mainstem bronchus minus the width of the right DLT bronchial cuff, which is nearly 8 mm in case of right-sided DLT. So how to choose the size of DLT? Depending upon the age, gender of the patient. In case of males, more than 170 centimeters, you use 41 French, less than 170 centimeters height, 39 French. In case of less than 160 centimeter male, 37 French is used. For females, more than 160 centimeter, 37 French DLT is used. Less than 160 centimeter, 35 French. And for short stature females, less than 150 centimeter, 32 French is used. It is available right from 26 to 41 French, but for Brodsky and colleagues found it is better to measure the tracheal diameter at the interclavicular distance in the chest X-ray PA view, as you cannot always see the left mainstem bronchus to measure. So they found a correlation between the measurement of the tracheal width, and they predicted left bronchial width according to that, and they recommended the DLT size. But Chow et al. Said this method is having limited utility in case of small stature patients with Asian descent. So they found CT scan measurements of the diameter of the left bronchus were useful in choosing smaller DLTs. So for left main bronchus diameter less than 10 mm, you choose 32 mm left-sided DLT. For those having a measurement of 10 mm, 35 French DLT is used. Also, Hanala and Benumov said the chest CT measurements of the left bronchial diameter, they successfully guide the choice of left DLT. You have to measure the left bronchus diameter on the CT scan one slice below the carena. Now, how to prepare and insert the DLT? You have to check both the cuffs for leaks and symmetrical inflation. There should be lubrication of the stillet, DLT cuff, and fiber optic bronchoscope. The connector should be assembled, keeping it ready for immediate connection. There are two methods of insertion, either the blind insertion or the fiber optic guided. You have to confirm it using auscultation and fiber optic bronchoscopy. Usually, for a patient of height 170 centimeters, the depth of insertion of DLT is 29 centimeters, and for every 10 centimeter increase or decrease, you have to change the depth of insertion by 1 centimeter. Also, you can use the formula 12 plus patient height divided by 10 centimeter to know the depth of insertion. Fiber optic bronchoscope is essential and mandatory for the DLT placement. It has been shown from multiple retrospective and prospective studies that in spite of auscultation and clamping method, there are 35% malpositions. You have to use a fiber optic bronchoscope. It is a mandatory by guidelines. DLTs of size more than 35 French, you use 3.5 mm fiber optic scope, and for those less than 35 French, you use 2.4 mm fiber optic bronchoscope. Now, how to insert the DLT? You have to hold the DLT in such a way that the concavity is upwards, and then you, after the direct laryngoscopy or VDL scopy, you insert the bronchial cuff. Once the bronchial cuff passes the vocal cords, you turn the double lumen tube anticlockwise 90 to 120 degrees in case of left DLT placement, and clockwise rotation by 90 to 120 degrees in case of right DLT placement. And then you do a sequential clamping and auscultation technique. Initially, you inflate the tracheal cuff and hear the bilateral lung field sounds. Then you clamp the tracheal lumen. Then you can hear. Also, you have to inflate the bronchial cuff that time. And then you clamp the tracheal lumen, you hear air entry only on the left-hand side, and there is no air entry on the right lung. And when you declamp the tracheal limb, again you hear the air entry on both the sides. And once you clamp the bronchial limb, you will hear the air entry on the right hand side, and left hand side air entry won't be heard. This is the video presentation of the left sided DLT insertion and confirmation. During the video laryngoscopy, you put the bronchial cuff inside the vocal cords and then turn it 90 degrees anti-clockwise to insert the left DLT. For confirmation of the left-sided DLT, while using fiber optic bronchoscope, you should know the optimal view of the left-sided DLT. When you pass a fiber optic bronchoscope to the tracheal lumen, you will see the cuff as shown in the figure 1 o'clock position. There is a cuff on the left-hand side, sided mainstem bronchus, and you will see the trachealis muscle, which is going posteriorly in the right-sided right mainstem bronchus, which is having unobstructed view. When you pass the bronchoscope further onto the right upper lobe bronchus, you will see the image B that is showing a trifurcation of the right upper lobe bronchus. When you pass the bronchoscope through the bronchial lumen, you will get a view at 4 o'clock position, that is view C, and you will get a view, it is called as a secondary carina, that is bifurcation of the left upper lobe and lower lobe bronchus. This is the video presentation of the left-sided DLT confirmation. When you pass the fiber optic bronchoscope through the tracheal lumen, you will see the sharp carina and the tube with a cuff blocking the bronchial cuff blocking the left mainstem bronchus, while the right mainstem bronchus is having unobstructed view. You further pass the bronchoscope through the right mainstem bronchus. To confirm it is the right mainstem bronchus, you will see the trifurcation or the clover leaf sign, and thus you are sure that you are blocked the left mainstem bronchus. Moving on to the placement of the right DLT, the preferred technique is with a fiber optic bronchoscope guidance. Similarly, under the DL-scopy, once the DLT is passed beyond the vocal cords, you turn the DLT 90 degrees clockwise, and at the same time, you advance the fiber optic bronchoscope through the endobronchial lumen. You have to look for the tracheal carina, right mainstem bronchus, and right upper lobe bronchus. The optimal position is providing the good alignment between the opening slot on the endobronchial lumen of the right DLT to the entrance of the right upper lobe bronchus. This is again the optimal position. These are the structures which you have to look for. When you pass the bronchoscope from the endobronchial lumen through the Murphy's eye, you will get a view A, that is trifurcation, clover leaf sign. And after that, when you pass the bronchoscope through at the distal end of the right DLT, you will get a view C, which is showing the bronchus intermedius and the right lower lobe bronchus, which bifurcates further. And in the tracheal, when you pass the fiber optic bronchoscope through the tracheal lumen, you will get a view B, as shown in 1 o'clock position, blocking the right mainstem bronchus. This is again a video presentation of right DLT placement and confirmation. Passing the bronchoscope through the tracheal lumen, you see the unobstructed left mainstem bronchial lumen, while the right mainstem bronchus is. You further go into the left mainstem bronchus, the fiber optic bronchoscope, and you see the secondary carina. Now you move into the endobronchial lumen, onto the bronchial lumen of the right-sided DLT to confirm the optimal position of the ventilatory slot with the alignment and its alignment with the right upper lobe bronchus. Here you see the bronchus intermedius and the right lower lobe bifurcation, and you can see the ventilatory slot being adjusted aligned very perfectly. When you pass the scope through it, you will get the trifurcated right upper lobe bronchus. Now, what are the DLT complications? Malpositions are well-known complications of DLT. In cases of left-sided DLT, if it can be too far inside on the left-hand side, blocking the right mainstem bronchus. It can be out too far it's inside the trachea in cases of oversized DLT, where you block again the right mainstem, right lung ventilation. It can be too far down on the wrong bronchus on the left side, so blocking the ventilation of the left lung. In cases of right-sided DLT, malalignment of the ventilatory slot with the right upper lobe bronchus is hazardous. All these cause failure to collapse the desired lung, the hypoxia, and the failure to seal, causing contamination of the healthy lung. Patient position change, surgical manipulations, they are the reasons for DLT malpositions. Also, airway trauma because of the bigger size of the DLT. As a tube itself, the DLT is bigger. There are mucosal ecchymosis, dental trauma, arytenoid dislocations, tracheobronchial tree rupture, mostly in the membranous part of the trachea, causing unexpected air leaks, subacute emphysema, massive bleeding into the lumen. Bilateral pneumothoraces, tension pneumothorax have also been reported. So you have to be constantly vigilant by observing the changes in the peak airway pressures, end-tidal CO2, SpO2, and the mediastinal movement. And fiber optic bronchoscopy is the gold standard you have to do while after changing the patient position, and in case you find any change in the above parameters. What are the steps you have to carry out from induction to the one lung ventilation? You have to select the largest DLT which safely fits the airway. Remove the bronchial stellate once the tube is past the vocal cords. You have to be extra cautious in patients with tracheobronchial wall pathology. Avoid frequent suctioning through fiber optic port. Advance DLT into the bronchus as we have mentioned earlier as per the patient's height. You have to inflate slowly the bronchial cuff. 2 to 3 cc of air is adequate with proper size DLT, and cuff pressure monitoring. You have to deflate both the cuffs when one lung ventilation is not needed and when you're about to move the patient. Denitrogenation with 100% FiO2 3 to 5 minutes before starting of the one lung ventilation. Alveolar recruitment maneuvers just prior to beginning of one lung ventilation, they help increasing lung compliance. After start of the one lung ventilation, you can reintroduce the air gas mixture. You can suction DLT lumen to improve lung collapse in non-ventilated lungs. Now you have to, there is much talk on the intraoperative ventilatory strategies. They aim to prevent the intraop hypoxia and prevent the post-op ventilator-induced lung injury. You have to set tidal volume from 4 to 6 ml per kg. Apply PEEP of 5 to 10 centimeter with a respiratory rate 15 to 18 per minute. FiO2 50 to 80% is routinely used. Maintain the airway pressures peak less than 35 and plateau less than 20. Maintaining I ratio 1:2. Minute ventilation should be such that you can accept PaCO2 up to 50 to 60 mmHg, permissive hypercapnia. Pressure control ventilatory mode is superior to volume control ventilatory mode in patients with respiratory disease. In normal patient, there is not much difference in either mode of ventilation. If there is episode of hypoxia during one lung ventilation, how you go about it? Firstly, you have to increase the FiO2 to 100%. If it is life-threatening, that if it is causing arrhythmias or some STT changes, you have to immediately stop the surgery and resume the both lung ventilation. If it is non-life-threatening, you continue one lung ventilation and treat the treatable causes like the malposition, suctioning the secretions, treating the hypertension, the depth of anesthesia if it is too deep, treating the blood loss. And to improve the oxygenation, you can apply CPAP to the non-ventilated lung and PEEP to the ventilated lung, also using the recruitment maneuvers. To optimize the perfusion, inhaled nitric oxides, the nitric oxide can be used. Now, after one lung ventilation, after the case is over, how to go about for extubation. Prior to reinflating the collapsed lung, you have to suction both the lumens of DLT. Then operated lung, it re-expands unevenly. So initially you have to give high sustained pressures to open the atelectatic part, and then subsequent inflation requires lower pressures. The sustained inflation at low levels of PIP 20 to 30 centimeters of water for 10 to 15 seconds. Also, you can use alveolar recruitment maneuvers to optimize the pulmonary function. Use minimum FiO2. Also, to check the integrity of bronchial repair, you have to apply increasing level of inflation pressures up to 30 to 40 centimeters of water and manually watching for the air leak. All the patients should be extubated after most of the thoracic procedures, as positive pressure ventilation places stress on the bronchial suture lines, causing air leak and bronchopleural fistula. But those cases which are prolonged and complicated, they may require post-op ventilation due to the potentially edematous airway, upper airway, there is a need of continued lung isolation in selected cases when there are chances of airway trauma, hypoxia, when there is an increased risk of dehiscence and pneumothorax. In such cases, after safely resuming two-lung ventilation, you exchange the DLT with a single lumen tube over the exchange catheter and you can ventilate post-operatively. Recently, you have video DLTs, Dr. Satish Kumar. They have reported the safety and efficacy of this video DLT. You get camera embedded in the between the tracheal and the bronchial lumen. They say it is efficient and safe alternative which almost eliminates the need of fiber optic bronchoscope. It takes significantly less time to isolate the lungs and you get a real-time constant visualization to check the adequacy of bronchial cuff inflation and you can diagnose the malposition early. Ambu has also launched similar Viva site DLT with a camera embedded between the two cuffs. What in cases of difficult airway, in cases of already intubated patient, how do you achieve lung isolation? The patients with tracheostomy in place, there comes the need of the endobronchial blockers. The specific indications of endobronchial blockers are the difficult airways, limited mouth opening when you do the nasotracheal intubation or awake orotracheal intubation, intubated patients in ICU requiring lung isolation, tracheostomized patients requiring lung isolation, and patients who require selective lobar blockade. The bronchial blocking techniques involve the blockade of the mainstream bronchus to allow the lung collapse distal to the occlusion. Previously used Fogarty occlusion catheter, but its disadvantage that it doesn't have a hollow central lumen which doesn't allow oxygen suctioning, the torque control univent blocker which we will see in the next slide, and the independent bronchial blockers as shown in the diagram, the wire guided endobronchial ANT blocker, the Cohen flexitip endobronchial blocker, the Fuji uni blocker, Coopdech blocker, and the easy blocker as shown in the figure. Image D. Torque control univent blocker is a conventional endotracheal tube made of silicone with an incorporated channel containing coaxial movable bronchial blocker. But the margin of safety of this univent ETT is not being investigated. Now coming to the independent bronchial blockers, the ANT wire guided endobronchial blocker is available as a 5 French, 7 French, 9 French catheter with side hole present only in 9 French at the distal end. It is having a Cook's multiport adapter and a flexible nylon wire inner lumen from the proximal end of the catheter to the distal end exiting as a wire loop which serves as a guide wire to insert the blocker with the help of fiber optic bronchoscope. It is having high volume, low pressure cuff. How to place it? Initially, you arrange the endobronchial blocker with a wire loop entangled with a fiber optic bronchoscope, and then you attach the multiport adapter to the single lumen tube, and under the direct vision, you simultaneously go fiber optic bronchoscope as well as the bronchial blocker. And when you find the blocker has deflated, it has passed the bronchus, then you can release the wire loop and inflate the blocker. The image A and B shows the optimal position of the bronchial blocker in the right mainstem bronchus, image A, and the left mainstem bronchus. The Cohen flexitip blocker is available as a 9 French, 65 centimeter, having high volume, low pressure curve. It is having a spherical balloon with the side holes at distal end. It is the mechanism here is the wheel as compared to the wire loop. It is a wheel turning device located approximately to allow already pre-angled tape deflection at the distal tip. You also have a torque grip at the 55 centimeter mark for rotating the blocker. Now, how do you insert? You can see the arrow in the upper image just above the balloon. Using fiber optic bronchoscope under the direct vision, you can twist the endobronchial blocker to the desired side and look for the optimal position of the blocker that is at least 5 mm below the carinum. The Fuji uniblocker is available in the sizes 4.5 French and 9 French. It is again having high volume and low pressure curve. It comes with a swivel connector. It is having incorporated torque control shaft which allows guidance into the desired target bronchus. It can be placed through the glottis or tracheostomy, and it can be passed external to the endotracheal tube in cases of small patient. Coopdech blocker, which we use type A and type B. Type B is having auto inflator balloon while single-handedly when you are working, you can just press the auto-inflator button as shown here, and then you inflate the distal curve. You get the rectangular round shaped curves or the small spindle shaped curves. This assembly is blocker tube clamp. This is the ventilatory port and endotracheal connection. From this port, bronchoscopy port, you can put the fiber optic bronchoscope. How to insert? Initially, you have to check all the blockers by checking the integrity of the cuff and the volume needed. There are two methods simultaneously. Your assistant is holding the fiber optic bronchoscope and you are passing the Coopdech blocker, and then you can see it can be moved onto the left bronchus for blocking the left lung or into the right mainstem bronchus by just turning the blocker so you pass simultaneously the endobronchial blocker as well as the fiber optic bronchoscope, and then you can confirm the position of the blocker. It should not herniate above the bronchial lumen. Also, you can initially insert the Coopdech blocker blindly, and then you can ventilate the lung, and after that you can pass the fiber optic bronchoscope to optimally position the cuff inside the left side. The position of the cuff should be noted. It should not herniate into the carina. It should be optimally inside the left mainstem bronchus, usually 5 mm below. There comes the easy blocker, which is available in 7 French size, which is 75 centimeter long. It's having two different lumens for inflating the cuff, the color-coded blue and yellow cuff, the Y-shaped distal portion. This distal portion facilitates the anchorage of the blocker onto the carina, and you can inflate either balloon depending upon the isolation of the desired lung. And this research article by Moritz and colleagues says 99% of the easy blockers are placed free of complications, and it is efficient, easy to use alternative to conventional DLTs. Let us see the video presentation of the easy blockers. Initially, you have to check both the cuffs, amount of air you need to inflate. Here it is recommended rather to insert blindly the easy blocker through the single lumen tube until you get a resistance. And after that, you start ventilation and then pass the fiber optic bronchoscope to optimally position the easy blocker. Specifically for easy blockers and Coopdech blockers, you need to have a working space that is inside the carina. You should have around 2 to 2.5 centimeter space so that you can maneuver the endobronchial blocker. You can rotate it, you can take it out. So you need to take out the single lumen tube slightly above if it is not working. As in this case, when you pass a fiber optic bronchoscope, you will see both the ends are inside the left mainstem bronchus. So you need to take out your single lumen tube a little above, and then you take out the bronchial blocker, make it work so that the bifurcated end sits on the carina. And then you can have two lumens, either one lumen in each mainstem bronchus. And depending upon the desired lung isolation, you can inflate the balloon. So this idea of having adequate working space for the endobronchial blocker should be kept in mind. And you have to adjust the single lumen tube position according to that. Right balloon is inflated. This is a combined chart showing the properties of the different endobronchial blockers. Now, what are the pitfalls of the bronchial blockers? They require longer time to position. They often need intra repositioning. They cause slow lung collapse. So you have to suction it for few seconds at intervals and with low pressures, because there is the risk of developing negative pressure pulmonary edema, and that causes severe hypoxia. There is difficulty in suctioning in cases of bronchial blockers. Switching from one lung to two lung ventilation is difficult. Especially right-sided placement is challenging. There have been reports of fracture of tip of Coopdech bronchial blocker, more so while placing it in the right mainstem bronchus, because you get a Murphy's eye on the right side of the single lumen tube. If you pass the Coopdech blocker through the Murphy's eye, there are chances of fracture of the tip of the blocker. While comparing the DLTs and bronchial blockers, DLTs allow easy suctioning. These are the best devices for the absolute indication. The switching from one to two lung is easier and reliable. While in bronchial blockers, the advantages are it is the best device for the patients with difficult airway. There is no chance of cuff damage during the intubation. There is no need to replace the tube if you plan post-operative mechanical ventilation. While the disadvantages of double lumen tubes that there are no objective guidelines to select the proper size of the tube. It is more difficult to place, and there is a potential damage to tracheal cuff during the intubation. While in case of bronchial blocker, the disadvantages are the suctioning, as we have mentioned earlier, is difficult, and conversion from one lung to two lung is problematic. What to choose, whether DLT or endobronchial balloon? It depends upon the patient pathology, patient safety, the surgical procedure for which you are doing lung isolation, the difficulty of airway, the tracheobronchial anatomy, and obviously the anesthetist comfort with the selective device. If there is availability of fiber optic bronchoscope in your theater, and the experience of anesthetist. In cases of difficult airway, when you can anticipate the difficult airway, there are reports that you do awake intubation orally and nasally, go with the bronchial blockers for lung isolation. But if it is unanticipated, when you induce the patient and you come to know that it is difficult intubation, you put LMA. With the use of intubating LMA, you can pass the tube over the LMA and then bronchial blocker. Or there are even reports that bronchial blockers are used through the LMA. This is a diagram showing Coopdech bronchial blocker catheter inserted in the Procil LMA, and they carried out one lung ventilation in this case. In cases of tracheostomized patients, the lung separation is obtained with conventional DLT by passing the conventional DLT through the stoma, tracheostomy stoma, or the short Ruke DLT is or can also be used. There's a diagram showing the use of Cohen blocker and the wire-guided endobronchial blocker via tracheostomy. So to summarize, the ABC of lung isolation: A for anatomy, B for fiber optic bronchoscopy, C for the CT scan or chest X-ray. It's crucial to understand the anatomy of the patient, review the relevant imaging preoperatively. The optimal technique of lung isolation depends on the indication of one lung ventilation, patient's airway, expertise of anesthetist, and availability of fiber optic bronchoscope. To achieve 100% success, every lung isolation device placement requires auscultation, clamping maneuvers followed by fiber optic bronchoscopy. And understanding the physiology of one lung ventilation and its clinical application reduces the ventilator-induced lung injury. These are my references. Thank you so much.